This week is everything about pancreatic disorders and neoplasms of the GI tract, which I think I hit them all. I tried to double check myself. I already found out that I forgot to mention a bunch of different surgically relevant hernias, so that'll go in next week's episode. But for today, we're going to stay focused on a couple pancreas disorders, go through the malignancies, and then we will see you guys next week. We're already almost done with the GI system, which is wild to me. So I am just thrilled because it's been a lot to organize my notes, and I'm looking forward to touching the other topics that are relevant and trying to maybe work a little bit ahead because I have some trips coming up in a couple months. So I am trying to prepare myself to have things ready to go and just posted with myself not being in the country. But all that being said, let's go ahead and just start with this week's study tip. I wanted this week to talk just briefly about timing of studying, which I think I've mentioned briefly in the past how important this is, but I'm trying to talk about specifically how to actually break up your timing. If you want to sit down and study for 4 hours or 2 hours or 1 hour, what should your timing be? If you're alone or if you're with another person or however you might have it set up. I personally really liked the Pomodoro method, which is actually it's a free website that you can Google, and it's truly a timer based on this method where I guess the idea is essentially that your brain can't continue to learn new information or retain long-term memory information after a certain period of time. So if you break up your studying into 25 minutes or 15 minutes and then take a 5-minute break, you've reset the clock and now your brain has been rewired to refocus and is primed to retain more information than it would have if you just studied for 4 hours straight. I am somebody who is very guilty of trying to just study for 2 hours straight and not take a single break. And when I finally realized that it's better to break things up into smaller pieces, I actually did retain information much, much better. And this goes even if you're with another person. So when I would study with my best friend in PA school, we would still, even if we studied for 30 minutes, we would stop, we would take a walk around the building, or we'd go get dinner, or honestly, sometimes we would put on Netflix for like 5 minutes. And then we'd say, okay, we really want to watch more Netflix. Let's go ahead and refocus. And then we'll do a couple more topics or whatever we were studying that day. And then we said, okay, well, we can watch some more Netflix after that. Kind of silly, but anything you can do to motivate yourself. I've heard of people scheduling workout classes or using a computer timer or just what's on their phone, using different, music to keep themselves on time, I guess. So there's different ways you can do it. My point being, don't just sit there and try and go through everything all at one time. It's just not effective. There's plenty of science to prove that doesn't work. So don't beat your head against a wall and do the same thing over and over again. Try something new and don't be afraid to do so. Now, this week is all about pancreatic disorders first and then malignancies, like you guys already know. So I'm going to go ahead and get us started right off with acute pancreatitis. Now, the definition, I truly am somebody who likes to keep things simple and to the point. So if a name has, suffixes and prefixes that make sense, then that's what it is. So the definition of acute pancreatitis is acute, short-term, or, sudden inflammation of the pancreas. Itis, inflammation, pancreas. So acute inflammation of the pancreas. Now, the etiology, 2 big things, gallstones or heavy alcohol intake. In general surgery, we kind of dance between the two, but gallstone pancreatitis is what I see most commonly. So I kind of have that one as my number one differential, gallstone pancreatitis, as opposed to jumping to alcohol-induced. However, you can also have just idiopathic pancreatitis or ERCP-induced pancreatitis. So if you've recently had an ERCP procedure, you can actually, I call it tickle the pancreas or make it mad and inflame the pancreas and have reactive pancreatitis after this procedure. Some other risk factors for pancreatitis are celiac disease, smoking, or just being an older individual. Generally, their presentation or history is going to be abrupt, severe epigastric pain, meaning right underneath that subxiphoid space, radiating to the back, that worsens with walking, lying flat, and it feels better when they sit forward. So, oftentimes in the hospital bed, patients will be sitting with the head of the bed up, clutching their knees, because that actually makes the pain feel better as opposed to laying flat on their back. Additionally, these patients often have nausea, vomiting, and weakness, and they could, of course, have, recent biliary type pain versus recent alcohol intake. So you kind of have to gauge that based on your history. Physical exam wise, like I said, you're going to see them sitting upright, leaning forward. They may be pale, cool, clammy skin. They could have some jaundice as well. As far as some other things that you would look out for, fever, tachycardia, the abdomen exam, oftentimes they are distended, tender in the epigastric region. It can be very severe, but they're not typically peritonitic. So they're not going to have that guarding or rebound tenderness, but they can be very, very, very tender. And oftentimes their belly is distended. That's not to say they're never not peritonitic. Just in the basic, what you're going to get as a test question, I don't think they're going to give you that. I think they're going to give you somebody who's sitting upright in bed, leaning forward, cool, clammy skin, clutching their stomach right over that subxiphoid area that is severely tender and distended. Now, the Ranson criteria, we're getting into diagnostics here, is an indicator of disease severity. So, age greater than 55, white blood cell count greater than 18,000, glucose greater than 200, LDH greater than 350, AST greater than 250. This is a scoring system that helps us predict the severity and possible mortality of acute pancreatitis. Although it's generally pretty rare, it can be very severe and possibly cause pancreas necrosis or tissue death of the surrounding tissue or the pancreas itself. And therefore, it's important to kind of use these predictive signs to reflect the severity of the pancreatitis. So you usually assess these based on their hospital admission, and then the rest, some of them you do right when they're getting admitted, some of them you do at 48 hours after admission, and you can kind of check to see if they're getting dehydrated, if there's sepsis brewing, if there's anything else going on in the background of this. And I don't think you're going to get quizzed too much about how to use it, besides the fact that it's an indicator of disease severity, and those 5 criteria in particular, I think, are the most important. Now, there are some other lab values that are important as well, including amylase lipase. Usually we're trending lipase more so, but these can be significantly elevated, 3 times normal. I've seen lipase in the tens of thousands or more even. You're also going to check a CBC and a CMP. And just like we mentioned above, right, you're going to see leukocytosis, hyperglycemia, elevated serum bilirubin, elevated serum alk-Phos. If they are dehydrated, they could have an AKI even. So you could have an elevated creatinine or BUN or BUN. People call it BUN. The other things that you can check are oftentimes you're going to get that CT scan. It's not going to do too much besides show you an inflamed pancreas. You're going to have to kind of do serial exams and monitor them with serial labs as well. And then you can possibly re-image them as you go through treatment. Generally, the treatment for mild pancreatitis is to give everything a break. So by that I mean bed rest, IV fluids, pain management, and generally we start them initially NPO, but the new trend is to quickly advance them. So I think for your test, you're going to get NPO, bed rest, possibly an NG tube with rehydration. But we usually try to resume oral intake as soon as their pain starts to improve. For severe treatment, we're going to start giving them lots and lots of IV fluids for several monitoring. Sometimes these patients are even admitted to the ICU to help stabilize their vitals, monitor their central venous pressure, and make sure they're not getting dehydrated. So you don't want to give them too much fluid, especially if you have a patient with other comorbidities. But generally speaking, test question wise, you're going to rehydrate, give them NPO or bowel rest. Now, again, there are some complications that you need to be aware of, including things like pancreatic necrosis, which could become a surgical problem, infection, chronic pancreatitis, SIRS, sepsis type stuff. You could also end up with acute tubular necrosis, pancreatic abscess, or pseudocysts. Again, not necessarily surgical, but those could be things that you need to intervene on regardless. As far as next up, chronic pancreatitis is kind of like an adjunct to this. This is oftentimes where you're going to more so see these cases occurring in patients with a history of alcoholism. They are essentially having this long-term inflammation of the pancreas that is causing some kind of functional impairment. So generally, they're going to have these recurrent or persistent episodes of pain, as well as weight loss, nausea, vomiting, and kind of those general symptoms. The difference is going to be that this is recurrent, it's happening in the past, it's happening over and over again. Similarly, you're going to check the same labs. The other stuff you can do, again, you can check imaging, you can get a CT scan, you can get an ERCP to image everything as well. Generally, the treatment for chronic pancreatitis is to provide them a low-fat diet, obviously recommend that they stop drinking alcohol, pain management while avoiding opioids, and then you can do some surgical intervention. Specifically, you can surgically manage any coexisting biliary tract disease that might be going on at the same time. You can also stent open the pancreatic duct or drain any pseudocysts that develop. So you would probably do that with an ERCP or an IR procedure, although this possibly can all be managed surgically as well. Complications of this, again, think about what your pancreas does. So oftentimes these patients can develop diabetes. They can develop opioid addiction due to chronic pain. And the most common cause of death for this one is pancreatic cancer. So this is one that I think is important. Oftentimes, chronic pancreatitis is very disabling, and so they're kind of being chronically worked up for this condition. Moving right on into our neoplasm section, I'm keeping it right along path. So I'm starting with pancreatic cancer because I think it's important to remember that you've got your acute pancreatitis, your chronic pancreatitis. The most common cause of chronic pancreatitis is pancreatic cancer. So now we're going to talk about pancreatic cancer, which is the fourth most common cause of cancer deaths in the United States. 95% of the time, this is due to an adenocarcinoma found in the head of the pancreas. So I had somebody in class last week ask me where pancreatic cancer usually occurs and what kind of surgical interventions you can do. And head of the pancreas, it's usually adenocarcinoma. Risk factors for this: age greater than 55, generally more in male patients than female, a history of chronic pancreatitis, and smoking. So I like to create vignettes in these situations and try to put a picture of somebody. So I do try to use this based on the questions that they're going to give me, just so I know this is the type of patient that I should be thinking about. And if I can get a couple of the right vignette pieces, then that helps me when I actually take the test. So for somebody who's presenting with pancreatic cancer, I'm going to be thinking about a 65-year-old male with a history of alcohol and smoking use and a history of chronic pancreatitis. So that's kind of what I use when I go to take the test. So if they give me somebody with 2 or 3 of those things, I have an idea of what the question's going to be about. Now, presentation-wise, again, these are going to have these non-specific pancreatitis symptoms, but these patients are also going to have weight loss, painless jaundice, and kind of more of those chronic type red flag type symptoms or B type symptoms of cancer. Lab work, you're going to get LFTs, and once you have this diagnosed and you're managing treatment, a CA19-9 is the tumor marker that you're going to use. But the test of choice for this is a CT scan. Now, you can get an endoscopic ultrasound, but for your test questions, just remember CT scan is the test of choice. Now, the treatment for pancreatic cancer, 20% of these patients are surgical candidates, either with a pancreatectomy or a Whipple procedure. You can also do things like radiation, chemo, pain, and palliative type therapies. And generally speaking, this is not a condition or diagnosis that people like to get. Pancreatic cancer has a pretty poor prognosis. That's just the nature of this one. So I do try to remember that this is a neoplasm in the GI tract that has a high mortality rate. The Whipple procedure, I wanted to very briefly talk about. It's the primary surgical treatment for pancreatic cancer patients. So if you're interested in surgical oncology or anything like that, then this is a pretty important procedure to know about. This is essentially a pancreaticoduodenectomy. It's a major surgical operation. And basically, they are en bloc removing the distal part of the stomach, the first and second portions of the duodenum, the head of the pancreas, the common bile duct, and the gallbladder. Oftentimes, they're also removing the lymph nodes. So just think that they're taking out everything that could possibly be kind of involved in what the pancreatic cancer, I guess, could involve. So if you're going to think about pancreatic cancer is usually in the head of the pancreas, just remember that lymph nodes in that surrounding area are going to spread to those areas. So what are the things that are going to interact? Distal part of the stomach, the first two parts of the small bowel, common bile ducts, and the gallbladder, as well as the, obviously, head of the pancreas. So that is really pancreatic cancer in a nutshell. I think I kind of got a little bit rambly. Don't worry, we're going to keep rambling right on ahead into malignancies of the colon and rectum. Now, this is the second leading cause of death from cancer in the United States. And generally, we actually are making progress. This has a decreasing mortality rate, and there's increasing screening over, the past several years, which is great. The other thing I like to kind of debrief when I'm talking about malignancies is there's risk factors and protective factors. You're going to hear me mentioning both of those. Risk factors for malignancies of the colon and rectum. 90% of the time, this occurs in patients older than 50 years old. Not a be-all, end-all, as we'll talk about later, but pretty important. Oftentimes, there is a family history of polyps or colorectal cancer. There is a history of IBD, smoking, diabetes, diet high in red meat/fats, and 75% of the time, none of these risk factors are occurring, and they just end up being diagnosed with colorectal cancer. So bear that in mind. Some protective factors, they diet high in fruits or veggies, fiber, physical activity, vitamin D, all the things that you think about when you have a pretty well-rounded diet. So, that one's, I think, pretty easy to remember. Oftentimes, the etiology of this, so adenocarcinoma often arises from a colon polyp. So commonly, these are adenocarcinomas. Now, also, these could be due to hereditary syndromes, which I'll mention briefly, such as familial adenomatosis polyposis or Lynch syndrome, which is hereditary non-polyposis colorectal cancer. Talk about that later, but think of those three things. It's usually hereditary or adenocarcinoma as far as your test is concerned. Presentation depends on where your cancer is. So think about where a tumor is in the colon and use that to guide you. Again, I like to keep things simple. I just like things to make sense. So if you have a right-sided colon mass or a proximal colon mass, these patients are going to have fatigue, weakness, iron deficiency anemia, a positive fecal occult blood test, and they have a larger colon diameter on that right side. So there's less of a chance that you're going to end up with an obstruction because of it, but you will have the symptoms of it. So you'll have things like that iron deficiency anemia, those B-type symptoms. Now, if you have a tumor on the left side of your colon or the distal colon, this has a smaller diameter and your solid stool changes, right? So your stool size is going to change. So these patients are going to have abdominal pain, bright red blood per rectum, blood-streaked stool as opposed to darker melena type stool. Additionally, they may have those obstructive type symptoms, right? So they may end up with constipation, inability to pass gas, distension, nausea, vomiting, etc., etc. As far as your physical exam goes, oftentimes it's normal. You may be able to palpate an abdominal mass. However, you could, also not. I mean, these tumors can be anywhere in the colon. So you can possibly feel a mass. Sometimes you can actually feel these on digital rectal exam. But if you have a patient who's over 40 years old with a change in bowel habits, bright red blood per rectum, iron deficiency anemia, unexplained by another cause, you have to prove it's not cancer. So you're going to have to work them up. Differential, again, these could be patients with IBS, diverticulitis, ischemic or infectious colitis, inflammatory bowel disease. Wow, these are a lot of I's. Or hemorrhoids. However, I like to recommend that you rule out the things that can kill people. So rule out the big scary stuff first. Lab work, you're going to get a CBC, LFTs. CEA is the tumor marker for this one. It's usually elevated on presentation and should decrease after surgery or chemotherapy. You can also do a fecal immunochemical test or a FIT test, just like a fecal occult blood test, except a FIT test detects hemoglobin. You can also do fecal DNA tests, which is a FIT test plus Cologuard, usually. Diagnostics, your definitive diagnosis is going to be a colonoscopy with biopsy. That being said, there are lots of other options. So you can also get a barium swallow, a CT colonography, a barium enema. And staging wise, we use this TNM system. So they're usually going to get imaging, CT scans, pelvic MRIs, endorectal ultrasounds, things of that nature. The one that I think is important for this is definitive diagnosis is a colonoscopy with biopsy. And oftentimes you can see this apple core lesion. So it looks like you've taken a bite of an apple. So it's kind of got that C-type shape that's usually seen on barium enema. Treatment-wise, it depends on the stage. So there's various different stages. I don't want to get too much into the detail, but oftentimes if it is a stage 1 tumor, you can do surgical resection with lymph node dissection, and you can also do surgical resection for all of these stages. The difference being that sometimes you start reaching to this point where you're doing surgical resection for a palliative measure, as opposed for the goal being to achieve remission. So there's more push for pre-op chemo to help decrease the size of the tumor before you do surgical resection, and you often need really good imaging. That being said, you can technically do surgical resection for all stages. It just depends on what your goal is turning out to be. Now, like I mentioned earlier, screening is really important for these patients. It is a endorsement by the USPSTF. It's super important. I think people really recommend that you study this because there are oftentimes, I feel like you get asked this a lot on the test. Now, oftentimes, we recommend a colonoscopy every 10 years from ages 50 to 75, a flexible sigmoidoscopy every 5 years, or earlier depending if they have a family history. So oftentimes we recommend starting things at closer to 45 or even 40 years old, but for your test, the USPSTF recommendation is a colonoscopy every 10 years from ages 50 to 75, or a flexible sigmoidoscopy every 5 years with FPBT every 3 years. That's a lot of words. You can also opt for that Cologuard option now. That's, I think, officially endorsed as well. The screening options are long and numerable. So again, fecal cold blood test, guaiac test, fecal immunochemical tests, Cologuard, all of these things. The things that I think are important for this are the flexible sigmoidoscopy and the colonoscopy. So flexible sigmoidoscopy is a 60 centimeter scope. There's no anesthesia required. This can be performed by PAs. It can be great if you can see everything in that range, but this does not allow you to see the proximal colon. So if you do find a polyp, a colonoscopy is indicated. Colonoscopy is the most sensitive screening tool, but it can still miss polyps. So this has the best result with excellent prep and a careful examination. There's a very low rate of complications. It should be performed every 10 years or sooner based on the recommendations of the person performing your colonoscopy. And yeah. Prognosis. Stage 1, 90 to 100% survival rate. Stage 2, 70 to 85. Stage 3, 30 to 50. Stage 4, still improving. Median survival rate is about 30 months. And the rectal cancer itself, this has a lower long-term survival rate than colon cancer and a higher post-surgical local recurrence rate. That's just the nature of rectal cancer. Now I'm going to talk very briefly about the two genetic conditions related to colorectal cancer. The first being familial adenomatous polyposis. This is an autosomal dominant condition that is often confirmed by genetic testing. It's caused by the APC gene 90% of the time. The rest of the time, it's caused by MUTYH gene. This basically causes you to develop hundreds to thousands of polyps, which just by nature of that increases your risk of those turning into tumors. Most of the time patients have polyps by age 15 and cancer by age 40. So for this one, we often do a prophylactic proctocolectomy before 20 years old, upper endoscopy surveillance every 1 to 3 years for adenomas. And there is this kind of tidbit like celecoxib may reduce polyps. I think that's more so just like a fun fact. But essentially, we're intervening on these patients around age 20 because the risk is so high. Now, the next one we're going to talk about is Lynch syndrome. This is, again, an autosomal dominant mutation. This one is different. So we have, in the first one, we were talking about genes that kind of cause over development of polyps. For the Lynch syndrome, it's an autosomal dominant condition which inactivates tumor suppressor genes. So young patients are at a high risk of developing cancer of the colon, endometrium, ovaries, bladder, and other organs, as opposed to just strictly the colon. Now, if you do have family history of these cancers or multiple family members, then obviously you're going to be intervening sooner. We recommend screening at every 1 to 2 years, starting at age 25, as well as screening all family members. So we try to catch these genetic mutations in addition to just doing the general screening for the malignancies. So that's something to bear in mind as well. Finally, moving on into hepatocellular carcinoma. This is aggressive and a difficult to treat condition. Hepatocellular carcinoma, remember, carcinoma and hepatocellular, it just sounds like liver cancer, so that's what it is. Risk factors: hepatitis history, chronic alcohol abuse, age greater than 55. Those are the ones that I think of the most. So for this one, I think of a chronic alcohol abuser, about 65 years old, who has a history of hepatitis treatment. Presentation: oftentimes this is a patient who has known cirrhosis who is suddenly deteriorating. Diagnostics: they're going to have a leukocytosis, elevated LFTs, and imaging, you're going to get a CT scan with contrast, and the diagnosis of choice is a liver biopsy. So you're going to see on the CT scan, and then you're going to perform a liver biopsy. Now, treatment, pain management, screening all cirrhosis patients, providing all vaccinations, and chemoradiation. I don't feel like getting into the details of all the chemoradiation options for these different malignancies because I just don't think they're going to ask you that. Now, patients who have hepatitis B, they get an abdominal ultrasound every 6 months as well as an alpha-fetoprotein. So that's a tumor marker for this one, alpha-fetoprotein. Esophageal neoplasms, there are two main ones that I'm going to talk about: squamous cell carcinoma and adenocarcinoma. For this one, there's two different types of, or two different etiologies, but it's kind of the same umbrella term. I keep my notes basically 2 columns, so that way I can say this is the same and this is different. So squamous cell carcinoma is the most common cause worldwide, and it's most common in the mid to upper 1/3 of the esophagus. Its most often risk factors are smoking and alcohol use. Now, adenocarcinoma is the most common cause of esophageal cancer in the United States, and this is commonly in the distal esophagus. Risk factors for this are Barrett's esophagus, smoking, alcohol, and high BMI. So, you can kind of already tell what the differences are, right? Squamous cell carcinoma worldwide, mid to upper 1/3, adenocarcinoma common in the United States, distal esophagus. The risk factors generally overlap except for the Barrett's esophagus. That is higher risk for adenocarcinoma. So if your question mentions Barrett's esophagus in relation to an esophageal tumor, it's probably not talking about squamous cell. Risk factors: aspirin or NSAIDs, particularly in the setting of Barrett's disease, which is interesting because that kind of puts you at higher risk of developing ulcers, but that is the truth. That is what I found in my notes. Presentation: these patients often have extensive disease by the time they become symptomatic, but essentially the symptoms are progressive dysphagia. So they're going to end up with solid food dysphagia, then progressing to include fluids. They're also going to have all those B-type symptoms: iron deficiency anemia, anorexia, weight loss, yada, yada, yada. Diagnosis-wise, a upper endoscopy with biopsy is your study of choice. Staging-wise, you're going to get an endoscopic ultrasound for staging. Treatment is surgical resection in combination with chemotherapy. Again, I'm not going to get into the details of that. Gastrinoma is next, or Zollinger-Ellison syndrome. This is a gastrin-secreting neuroendocrine tumor. It's most commonly found in the duodenum wall or the pancreas. So I think that the name is a little bit misleading, Zollinger-Ellison syndrome or gastrin-secreting neuroendocrine tumor. It's not necessarily in the stomach. It is a GI malignancy that secretes gastrin. Presentation: these patients are often going to have recurrent or refractory ulcers with diarrhea. So those two things don't totally make sense to go together, so I keep them together. Refractory ulcers with diarrhea. Diagnosis: you have to establish that they have elevated basal gastrin levels. So essentially you're going to get fasting lab values and their gastrin is going to be elevated. The confirmatory test is a secretin test. So basically, gastrin is inhibited by secretin. So if you give a patient secretin and their gastrin is still high, then you know that there's something going on and you should end up getting a CT scan. Treatment for this is surgical resection. If it is a very highly progressed cancer that, they're not doing interventions for, one other medical option is doing lifelong high-dose PPIs. So that is an option as well. Gastric carcinoma is what we're talking about when we're referring to true stomach cancer. The most common cause is adenocarcinoma, or most common type, I guess. The risk factors for this are H. pylori, poor diet, so preserved foods, a diet low in raw fruits and vegetables. And presentation-wise, these patients are, again, going to have that weight loss, anorexia. These patients, though, will have persistent epigastric abdominal pain, early satiety, postprandial vomiting, and that iron deficiency anemia. On physical exam, there are a bunch of lymph node inflammations that you can think about for this one. I just remember the two that I think are the most important. So Virchow node and Sister Mary Joseph. So Virchow is a supraclavicular lymph node. I remember this one because I think of the triangle made in your neck, and it kind of looks like a sideways V, and that's where the lymph node is. And then for Sister Mary Joseph, I don't have a great way to remember this one, but it is an umbilical lymph node. So if you have any creative ways to remember that, let me know. Diagnosis for this is an upper endoscopy with biopsy, and the treatment is gastrectomy and chemotherapy. So a lot of these malignancies have surgical intervention. It's pretty much surgical resection and chemotherapy and radiation, just depending. I don't think you're going to get asked necessarily specific chemotherapy medications. However, definitely something to review. I just don't think it's relevant for me to do so in this episode. More importantly, I think you should be reviewing the type of cancer. I think you should know major risk factors, what separates them from each other, what presentation-wise separates them from each other, the diagnosis of choice. So that is kind of what I think is most important. So if there's an important tumor marker, if there's something that separates it from everything else, those are the things that I think will help you best on your test. And I think that will kind of serve you best when you create those pictures in your head of what type of patient am I going to get when they give me this question. I think that vignettes are the most helpful way to study. So if you can picture the patient in your brain and then you get that as a question, you're set. So don't let them fool you with some of these, distractors in your questions, and keep things separate on things that, separate things from each other. So by that, I mean, if they're talking about a cancer of the esophagus that's in the proximal 1/3 and it's a test question, well, it's probably not going to be an adenocarcinoma. It's probably going to be a squamous cell carcinoma. Now, in the real world, can you have an adenocarcinoma in the upper 1/3 of your esophagus? Sure, but they're not going to ask you that on the test. So they can do all kinds of tricky stuff, but I think that they try to make things clear. I don't even know that they'll necessarily give you that as a test question. That all being said, this was a long episode. I apologize. I will try to edit this down to around 30 minutes, and I look forward to talking to you guys next week. Now, as I've said before, I'm kind of making these notes as I go, and I'm using my previous textbooks and up to date and trying to fill things in with my knowledge. So I think I'm getting better at keeping things in a straight line, but as always, any feedback is appreciated. I hope you guys have a good rest of your night, and I will talk to you guys next week.